Yes, it is. It is working. You can start now.
Okay, so I'm starting my talk. So dear organizer committee, dear colleagues, so I'm very pleased to present to your attention our result on a topic that I have been working for the last 10 years related to the pathogenesis, staging, and molecular phenotyping of bladder tumors. So all of you know that the most successful approach to treating a disease has always been an etiological therapy. In case of bladder cancer, however, this approach remains inapplicable, as the mechanism of disease development has remained to be fully elucidated. Just short intro into bladder cancer, so that over 90% of bladder tumors are transitorial cell carcinomas. They are frequently recurrent, but mostly they are not invasive. However, they are a very heterogeneous group with at least two distinct subgroups with different clinical pathological phenotype. Low-grade non-infiltrating cancer and high-grade infiltrating muscle-invasive cancer. In addition, based on their clinical behavior, non-infiltrating tumors are subdivided into non-progressive, which are 70% from them, and progressive types, 20%, whereas high-grade muscle-invasive cancers are subdivided into ones with relatively good prognosis, or maybe you can see it from here. Maybe we should.
Sorry to interrupt you, Antonova. We cannot see your slides moving. Still, it is showing first slide only.
You can't see the slides?
We can see the slide, but it is displaying only first slide. So next slides we cannot see. I think now you are in second or third slide.
So
you need to scroll the slides from your side.
Now can you see this? When I'm scrolling them?
No, we cannot see that.
Okay. So maybe like this?
Now it's visible. Yes.
So we will stay like this then. Okay, so now we'll stay then with like this. So okay, I will repeat that the tumors are mostly subdivided into low-grade non-infiltrating cancers and high-grade muscle-invasive cancers. So in addition, based on their clinical behavior, you can see now I go on the slide. Non-infiltrating tumors are subdivided into non-progressive, which are 70%, and progressive types. And whereas here the high-grade muscle-invasive bladder cancers are subdivided into two with relatively good prognosis and those with a poor prognosis and less than 5 years survival rate. So here you can see that there are actually many studies related to the development of bladder cancer at the molecular levels. Here I present different molecular pathways of oncogenesis in non-invasive and muscle-invasive bladder carcinoma. But despite the amount of data collected, the molecular changes found is still no answer as to what is happening to develop all these clinically different subgroups of the same disease. All these are required actually to improve our current knowledge on the clinical diversity and especially the specific molecular mechanism that underline the variation of the tumor behavior. So the aim of our study is actually to identify the correlation between molecular changes in the uroepithelial tumors and the tumor stage, grade, and progression, as well as to evaluate alterations in gene expression levels for potential prognostic markers. The materials and methods that we used actually two different approaches. Was first one, the gene expression analysis based on the differences in the expression between different bladder cancers and control. And the second approach was with copy number variation. So this is the first one, RNA approach. The second was DNA approach, and I will talk about them a little bit further. So here you can see the flow chart of our study. And first, just to say that the study protocol was approved by the ethics committee of our university, which is very important for each study. So bladder cancer samples were collected from 65 Caucasian patients, and they were taken so that the patients fulfilled one questionnaire about their lifetime use of tobacco products and occupational history. All the samples were immediately frozen in liquid nitrogen and stored at -80 degrees Celsius. All samples underwent histological assessment. So normal bladder tissue as a control was taken from patients suffering from benign prostatic hyperplasia. Complete staging procedures were carried out to determine precisely the tumor size, nodal involvement, and the presence of distant metastases, according to the well-known TNM classification. None of the patients had received any prior radiotherapy or chemotherapy. So this part of our study is related to the DNA study, or RACGH. So DNA was extracted using standard phenylchloroform extraction protocol and further stored at -20 degrees. Isolated DNA was quantitatively assessed spectrophotometrically and qualitatively by horizontal low-grade agarose gel electrophoresis. So here, for this approach, we used two independent platforms for detection of the genomic imbalances. This was cytochip ISCA from Blue Gnome and Infinium OncoArray BitChip Illumina, so which is with better resolution. A total of 20 bladder cancer samples were analyzed with OncoArray BitChip, and 12 cancer samples were analyzed with the cytochip ISCA. And 2 tumor samples were analyzed using both methods to confirm the robustness of the result. The clinical, so here I present the clinical and pathological characteristic of the studied cohort. And so they are presented here, and they are described according to the age of the patient, sex, smoking habits, professional risk factors, tumor stage, and grade. The mean age of the studied patients was around 68 years of age, and a total of 46 of them were smokers, with an average cigarette consumption of 16 cigarettes per day. 4 patients had professional risk factor related to the transport to oil and chemical industries. And actually, I will present you now the results very briefly because they are already published, and I will give you just the name of the presentation of the article if you are interested to look at this in the detail. A total of, actually, we found 524 aberrations, including 175 losses and 349 gains were detected. According to the tumor stage, the aberrations were distributed as follows: for the TA stage, 12%, T1, again 12%, T2, 63%, T3, 9%, and T4, 2.5% stage. So the mean number of aberrations per tumor was as follows: for TA was around 16 per tumor, T1 9, T2 25, T3 16 again, and T4 13. But for T4 we had only one sample because it's rare. Additionally, the number of aberrations were the highest for T2 stage tumors and the lowest for T1 muscle non-invasive tumors. Detected aberrations were distributed according to tumor grade as follows: 19.7% in G1. So this is according to their ability to invade, or the differentiation was 90% in G1, better tumor times for the patient, 37 in G2 and 43 in G3, so with high potential to invade. The total number of aberrations in G3 tumors was more than twice as high as that in tumors of the lowest grade, or G1. Excuse me. Okay, and according to the autosomal chromosomal regions, they were classified based on the number of the detected imbalances as follows. Group 1, we have 0 to 5 copy number variation detected. Group 2, 6 to 9 copy number variation detected, and group 3, more than 10 CNVs detected. So further, we are going to report only these CNVs from group 3, so this one with the most severe detection. Here on that slide are given all the variations found in all of the chromosomes, or in the chromosomes with aberrations. They are differentiated by color. So in the green one are given gains, in red one are losses. So you can see that in chromosome number 9 we have both gains and losses, and mostly in chromosome X we have losses. Also in chromosome Y, I don't know why it's not here. Okay, excuse me for this. Also we have gains and losses. So among the autosomal regions of copy number variation that has more than 10 different mutations, 79.9, so 80% of variations are actually 211 were chromosomal gains, while 20% were losses. Chromosome 9, as I already said, was the most severely affected, displaying 25 CNVs in the short arm and 23 in the long chromosomal arm, which actually accounted for 12% for all autosomal aberrations. Among the pathogenetic gains, 16%, excuse me, had overlapping regions in at last 4 or mostly 5 or 6, you will see further, different tumor samples, mostly high grade. So they will be demonstrated in the next several slides. So this is the chromosome. This is the top of the short arm. This is the centromere. This is the long arm. So on the X, so this is actually the chromosome 1. So on the X-axis indicate the genomic position. So this is the genomic position, and Y-axis indicate the individual tumor samples test. So this is one tumor sample, second, third, fourth, fifth, sixth, seventh, eighth, and ninth tumor sample tested. So in this case, we have found aberrations in 9 different tumor samples, which are overlapping. So this area, the shaded area, the shaded vertical fields indicate the start and the end of each overlapping CNVs. So here we have smaller region, so here we have bigger region. So the position of these regions and the tumor samples detected are actually included in this table. So the same stuff we report for chromosome 2, chromosome 3. So you can see there are different regions. Chromosome 4, chromosome 5, 8. So here we have 3, but very good regions. Chromosome 9, here we have gain regions and the region with losses, this punct here. Chromosome 10, 11, 14, 17, 19, 20, okay, and 20. Okay, and afterwards, so when we did this and we saw which regions are actually overlapping. So that is why we performed the follow-up analysis of these copy number variations that are focused on genes related to invasion and metastasis. So these the result of this analysis are actually demonstrated in a table. So you can see the region and the gene in that region that is related to these processes. Actually, we found 119 different genes, but as I already said, because this is already published work, so, and we are, I think, running out of time. So just if you're interested, I give you the name of the article. So this is clinical impact of copy number variation changes in bladder cancer samples, and it's published in the experimental and therapeutic medicine previous year. Oops, sorry. Okay, I think it's better. So actually, from all these 119 different genes, we found that certain genes are in these regions were already discussed and already reported to be involved in bladder cancer genesis and progression. So you can see the list of these genes. So, okay, so we continue with the second part of our job. So this is gene expression or RNA part. So actually, you can see this part of this, our flow chart. Here, total RNA was isolated using the ready-to-use Trizol reagent according to the manufacturer's protocol. So the double-stranded DNA, copy DNA, was prepared from actually 1 milligram of the extracted RNA using the RT2 first-strand kit for copy DNA synthesis, which contains a step for genomic DNA elimination. It's very important to include this step here. RNA yield and purity also were determined using nanodrop and the RNA integrity by 1% gel electrophoresis. First, we prepared 5 different pools from these isolated RNAs. Each pool was composed of tumor samples from the same tumor stage, PTA, PT1, and PT2. Also, we had one group for chronic inflammation, or this is precancerous group, which is positive control, and normal bladder tissue negative control. The relative mRNA expression of genes involved in the regulation of this cell cycle, DNA repair, drug resistant, metabolism, growth factors were analyzed with cancer drug resistant and metabolism and cancer drug according to the manufacturer's instruction from the QIAGEN. After these results, so we found several genes with upregulated and downregulated, but we selected these 4 genes, AP1S1, FIGF, and HDAC11 and CDK9 for individual validation or validation in the cohort of individual samples. For this validation, we used 40 different samples. And yeah, here you can see the explanation or the information about this gene. APS1, this is adaptor-related protein complex 1 subunit sigma 1. FIGF, this is FOS-induced growth factor, which is encoding VAGFT. CDK, you know, that is cyclin-dependent kinase 9, and HDAC11 is histone deacetylation 11, and actually it was found to be involved in one typical endemic disease for Balkans. So this is Balkan endemic nephropathy. So that's why we said it. Yeah, I thought it was interesting. So here are actually the results from the gene expression analysis, and the results revealed 4 to 12-fold chance differences in the expression level between PT2, so muscle invasive, to PTA or PT1, so muscle non-invasive tumors for all of the tested genes except for AP1S1, which is actually involved in protein trafficking by cluttering coated vesicles. So, in summary, I can say that the results obtained provide certain mechanisms that may be responsible for tumor invasion caused by genetic imbalances related to the activation of genes with metastatic and proliferative potential. A total of 42 recurrent CNVs, mostly in high-grade bladder tumors, were detected in chromosomes 1 to 5, 8 to 11, 14, 17, 19, and 20. Genes potentially related to the metastatic potential of the uroepithelial tumors were identified that may be, or I hope, may be further studied as a possible targets for precision therapy or some biomarkers. And these three genes, FIGF, CDK9, and HDAC11, can be further considered as a potential candidate biomarkers for the characterization of invasive tumor phenotype. But this work is still in preparation, it's still not published, so we are hope to publish it this year. So I would like to thanks to our grants, Bulgarian National Science Fund and the Medical University of Sofia, to all my colleagues, and of course to you for your attention. So if you have any questions,
Any question from audience side? Okay, thank you, Antonova, for your wonderful presentation.